Good morning, and I know I'm standing between you and lunch, so I try not to go over time. And thank you to PPMD for inviting Akashi to give an update on the HT-100 program. I've been coming to this meeting for 20 years or maybe more, and each year is really a pleasure to see the improvements, not just in therapeutics, but also in the way that we all present data to the parents. So, you know, I used to say that we will come out and the parents would say, it was all up to here. And today, you know, I think that we're really speaking to the parents, and I also want to thank the speakers and the speakers this morning, because it's amazing how this has changed. And I took a whole 2 minutes to say that. So, Akashi is a Duchenne company founded by parents, and we're in the business of trying to find drugs that work for Duchenne. So we have 3 drugs in our pipeline, and I'm going to spend most of the time talking about HT-100, but I wanted to let you know that we had 2 other drugs. HT-200 is an anabolic drug that works on muscle and basically makes it bigger and larger. It already has gone through 3 phase 1 trials, and we are ready to move that forward into a proof of concept study. And HT-300 is a drug that modulates calcium in the cell, which is one of the triggers for muscle cell death. And it has a very interesting mechanism of action, will be our first drug in class, and that is in preclinical stage and moving towards the studies that we need to do to initiate studies in humans at the end of this year. So HT-100. What is it? HT-100 is a very interesting drug. It's derived from a plant root, and it has been FDA approved for a long time for use in animals. So if you know, anybody that eats chicken probably has ingested HT-100, well, halofuginone, which is the active ingredient of HT-100. HT-100 is a formulation we did to improve the GI effects that the naked formulation had, and to also make the body absorb it better. It's an oral drug, so you can just take it, you know, it could be once a day, we give it twice a day. How does it work? Well, we found that this drug, although it was developed as a potent antifibrotic, actually shows very strong effects on reducing fibrosis, most exciting in reversing fibrosis. Also is anti-inflammatory, increases eutrophin in the muscle cells of dystrophic muscle, and also improves muscle regeneration. And if all this sounds too good to be true, it is because the drug target is actually an enzyme that helps making protein. So the drug tricks the body, acts on that protein and tricks the body, making them believe that it's starving. And when we are starving, our body goes into these pathways that are all orchestrated that tells the body, okay, stop using energy in anything that is not essential and only use it in things that are essential. So when you go to a disease stage, what is not essential are those processes that are happening in a chronic fashion just because it's abnormal, like chronic fibrosis or chronic inflammation. So it stops that and helps the processes that makes the tissues feel better, like increasing muscle regeneration or producing more, you know, eutrophin in the muscle. And that's why it works so well. And we have very promising data today that I'm going to share with you. So, but first let's go to the trials. We did 3 trials called DMD-01, 2, and 3. DMD-01 was a dose escalation and safety trial. And basically, the patients got 1 single dose. They stopped. We look at all the safety profile. Then they got 7 days of dosing. We stopped. We look at all the safety trial and PK. And then they went into a 30 days dosing phase. And if everything was okay, safety-wise, then they will roll into a 12-month study. And if they wanted to, they could continue in the DMD-03. So we did this, and it was a cumulative safety review after each phase and after each cohort. And we enroll up to 4 cohorts. So these patients, we enrolled 24 patients, 6 per cohort in 4 cohorts. The 2 low doses have been treated for a year and a half. The cohort 3, the medium dose, was treated up to almost a year. And the cohort 4 was terminated early because of a serious and unexpected adverse event that resulted in the death of a patient. So these patients were ambulant and non-ambulant, the 24 patients, and they were all corticosteroid treated. And the dose of corticosteroids was unchanged for a year before getting to the study, and all through the study, we didn't change the dose of the steroids. So the effects that you're going to see are on top of a very stable corticosteroid dose. And I've been at Duchenne, as I said, for 20 years, and I've been a clinician and seen hundreds of patients and treated a lot with the steroids. And this is the first time that I see a drug that produces the effects that you can see with the steroids, which is basically an improvement over the baseline. We are all happy if we can stop deterioration and just stabilize patients, but seeing improvements is really exciting. And these improvements were seen not just in ambulant boys, but also in the later stages, so in the non-ambulant boys. And this reflects what we saw in the mice when they treated all mice, and they saw this reversal of fibrosis and normalization of tissue. And that's why we wanted to have also the older boys in the study. And what we saw, this is muscle strength, the orange line. What we saw is that after about 6 months, patients are starting to get an improvement of muscle strength. This is just the lower dose cohorts 1 and 2, where you see even a more significant improvement of muscle strength. So it's about 15% and 20% when you look at both. And what you see on the gray line, we'll say, well, but how this compare with a comparative control? And this was an open label study. So the gray line is a closely matched external control, which is the placebo group of a similar study. And as you can see, the difference with the control, it was very significant at 12 months. Then we look at the non-ambulant patients, and there was a 2-year natural history study reported by Ann Connolly and the MDA groups showing, looking at what would be the outcome measures in the non-ambulant patients that we could use as surrogate markers of activity in these patients. And they identified in the early non-ambulant patients, which is a similar group to our non-ambulant patients, that elbow flexion, the ability to do this, was not only clinically significant, but also was the one measure that deteriorates linearly over 1 year. So we got that data, which is the gray line, and we look at how elbow flexion did in our non-ambulant patients. And what you're seeing here is that after a few months on the drug, there's a significant improvement of elbow flexion in the non-ambulant patients. And this improvement was about 23% over the patient's baseline, and when you compare to the external control, it was almost a 50% improvement.
Wow.
So this was very exciting, but because of the setbacks that we had with safety of the drug, and because the company has no intention to continue developing a drug if we don't think it's worth it and we're not excited, we decided to do more exploratory analysis and said, okay, so does this amount of muscle strength relate to improvement of function, of respiratory, of anything else? So we did an exploratory analysis with this external match control to see if we saw something else other than strength, and if this effect on strength was enough, right, to improve all the motor function or respiratory function. This data I'm going to show you, though, is exciting. It's not drug data that we're going to use to seek drug approval or anything like that. It's not appropriate for that. So the external control, as I said, is 32 patients from the DMD placebo arm of a Synergy clinical trial that we performed a few years ago of pentoxifilling. Why we selected this external control is because they were all in the same corticosteroid background. They were taken from a randomized controlled trial, so when the patients are on the trial, they are more controlled. There is no changes in physical therapy. There is no surgeries that are done during those 12 months. So it's a more stable group than the natural history. They were followed for the same 12 months. They have exactly the same methodology that the HT-100 trial. And however, they are not exactly matched. This external control is slightly stronger than the HT-100 kids and overall, which only makes it a more conservative comparison, right? So we have a high bar for what we did. And what we did is take each patient in the HT-100 and compare their change at 12 months in the many outcome measures that these patients did We compare that to the median of the external control and also to the top performers, right? Because maybe in our 16 patients, we have outliers and they're all just too good. So we said, well, let's go and compare also with the top 25% performers of the placebo group and see if we still can see good things. And if they were better than the median or the top 25, we'd give them a green dot. If they were the same, it was a yellow. If they were worse, it was a red. And I'm showing you just one color because it's easier to see. And I also want to right now take this opportunity to thank everybody that participated in this trial and did all these outcome measures, because it's the only way that we can look at this data. And we know it makes for very long days. So what you see here is time function test, pulmonary and function and strength measures, and muscle strength. And each one of these columns is a patient. And these are the non-ambulant patients, and these are the non-ambulant patients. And what you can see is a lot of dots, green dots, which means that those patients were better than the median of the control group in many of the outcomes that we looked at. And actually, if you look down here, you can see the 13 of the 16 patients have more than 60% of all the domains that we test that were better. And then when we raise the bar and says, well, but what about 25%? Are they better than the top performers? We still have a lot of patients that were doing in many things better than the top performers in both the ambulant and the non-ambulant groups. So we're happy about this. It says, okay, it looks like it's not just muscle strength. We have also other measures. Then when you look, and this is just one example, we wanted to know if the muscle strength correlated with strength, with function. And this is just one patient where you can see this is muscle strength improvement in this patient. He was 10 years old and he was in the low dose. And you can see how he improves in total muscle strength, and then the motor function measured by the MFM also goes up. His leg muscle strength goes up, and then you can see that after a period of deterioration, because this patient was coming down, he actually starts to improve the 10-minute walk run, the 6-minute walk test. The start climb velocity remains stable, and the hours after a period of coming down, it starts to go up again. And we can see the same thing in respiratory strength and function. So, okay, muscle strength is improvements are enough to affect function positively, and we were happy with that. What about safety? This data was presented last year as well. It's not new. So the 300 to 1500 cohort 1 to 3 boys were safe and well tolerated. The most common AEs that we had were GI and headaches. There were 307 adverse events related and not related to the drug, most of which were mild, few moderate. From the severe, there was one child that has severe vomiting when he started the drug, but then he was able to tolerate the same dose for almost a year. There was one episode of cardiac injury that at the time was called possibly related to the drug, but after that we have learned that this type of events do happen in Duchenne, so it's unclear. And then non-related. But we have one event that was fatal. This child was in the cohort 4 and have finished the single and the 1-week dose and was now in the 30-day dosing. And he presented in what's called vasogenic shock, so very low blood pressure that kept going down and did not respond to the blood pressure medications. We found that his halofuginol level was 7 times higher than expected, because we already have his blood levels from the 1-week dosing before. And he had nausea, vomiting, and abdominal pains, all these warning signs for 2 weeks that were treated with the drug that treat this, which is ondansetron. So we spent most of last year doing many investigations of what happened, and this is what we have learned. So what caused the death, and did HT-100 contribute to it? The answer is yes. We think that it was HT-100 at a very high level. It caused cellular injury. It was not at the blood level of the cohort 4. It was 7 times higher than that. Why was 7 times higher than that? We think that was in part following the repeat doses of ondansetron. There was some interaction with ondansetron. And also the fact that the child was taking ondansetron probably masked these warning signs of nausea and vomiting that, that would have triggered stopping the drug. We also ask ourselves, well, can these kids take a lot of over-the-counter medications, vitamins, and prescription medications? Did any of those alter the levels of halofuginone? So we look at 569 prescriptions and over-the-counter medications that the kids were taking, which are all here. And we did not see any changes in blood levels or safety signals with any of those. So we also ask ourselves, are there clear warning signs of toxicity? So if we see that, you stop, right? And that is important information. And the answer is yes. It's a combination, not isolated, but it's a combination of nausea, vomiting, abdominal pain, diarrhea, and headache. And when you had 3 or 4 of those together, and which happened in other kids in cohort 4, you can stop the drug, they resolve, you can restart at lower dose. So what is next for HT-100? We got off clinical hold early this year. We have learned, we have a clear path with the FDA. We're going to try a low dose of halofuginone, 150 micrograms to start with. We're going to contraindicate on ondansetron because we know that something happens with ondansetron halofuginone. Also, we don't want the patients to take antiemetics because if they don't feel well, we want them to stop the drug. So that's going to be part of the protocol. And we're going to be monitoring blood levels if the patients have to start a new drug or if they have to significantly change the doses of the drugs that they're taking. We're just going to monitor halofuginone levels in the blood to be sure that things are stable. So we're set up to start this study this year, in the second part of this year. It's going to be a clinical PK study. It's a small study to check that the blood levels of this low dose are the ones that we expect. So usually when you give this much drug, you get this much exposure. And in our trial, we said, we know that if we go up here, you got this exposure, you give more drug, you get high exposure. But when you go to a very low dose or a very high dose, your body might handle things differently, and we don't want any surprises. So the first things that we need to do is to be sure that a 150 microgram dose gives us the blood levels that we expect. This is going to be a small study, 6 patients. This is going to be done at probably just one site where they're going to, it could be ambulance or non-ambulance, steroid-treated or naive, because it doesn't really matter. And the patients that participated in the previous trials are eligible, and they're going to be prioritized to be in this study if they want to participate. They're going to be given a single dose, have PK for 24 hours, go home, come back day 7. They're going to start the 1 week of dosing, get PK, and come back at day 14 for the last dose, and then 1 more visit for follow-up. The patients that participate here are going to be in non-randomized arm of the next study, and that's something that we're going to assure. So they're going to be good for participating in a PK study. This is the last one. And the next study is going to be an efficacy and long-term safety study against placebo. It's going to be randomized and placebo-controlled, 12 months duration. We're going to look at safety and activity against placebo. And the trigger is going to be the results of this study. So if we have a linear exposure, as we expect, that's going to be the starting dose, and we have ways of escalating the dose if that is needed. So with that, I just want to acknowledge all the investigators that work really hard to collect all this data, together with the physical therapists and the coordinators at these sites, and the pharmacovigilance team. And many of you, Akashi has been funded by more than 27 Parents Foundations, and we really appreciate all your support. Thank you.
Well done.